preeclampsia with the existing guidelines is a challenge based only on high BPs and proteinuria and premonitory signs and symptoms. So it's very, very non-specific, and it's leading to clinical uncertainty. So what are we supposed to be doing? Why are we only doing consequence mapping? Why are we not looking at the root cause, which is nothing but the endothelial damage? This is what we heard in the morning. So it's all about abnormal placentation and endothelial damage. And because of this, you have a disturbance in the biomarkers. So just to understand broadly without any confusion, we have the good biomarkers, the good vascular markers, and the bad vascular markers. And the good ones are the PLGF, that is the placental-derived growth factor, and the VEGF, which is the vascular endothelial growth factor. And the bad ones, the bad one, which is commonly noted or commonly taken into account, is the SFLT1. So when you have a ratio, which is the SFLT1 to PLGF, you are trying to measure the host's response, that is the protective response in terms of PLGF to the inherent SFLT1, which could be probably indicative of endothelial damage. We have had situations where we have just prognosticated pregnancies using placental-derived growth factor. In fact, I have done a study on PLGF, but progressively what I realized was it was not very, very customized and specific because it did not take into account the host response to disease. We didn't know what was the endothelial damage which was inherent and the protective response of the host which could have probably manifested in disease. So what is important is to actually measure the damage versus protection, which is nothing but SFLT1 PLGF ratio. So this is the broad understanding of what we are going to do in the workshop. So these are the slides. I'm not going to really take into the details of this because we've heard enough of this. We know that there's altered vascular. This was the same slide that Dr. Sarosh presented. This was about the trophoblastic invasion. This is the typical Dr. Karumanji slide. And for the broader understanding, we know that there has to be a balance between the SFLT1 and the PLGF, and when there is a disturbance in this balance, that is what causes endothelial cell injury, and that manifests as preeclampsia, or what we call the bad form of hypertension causing problems. Just to give you a brief on what are the angiogenic growth factors. We have the SFLT1, we have the PLGF, we have the VEGF, and we have the S-ENG. We are not interested in the S-ENG because that is something that we don't really attach any clinical significance to. VEGF, yes, it's protective. In fact, VEGF-A is nothing but the PLGF. And VEGF receptors, one of the receptors is nothing but the SFLT1. So for broader understanding, what we have to understand is the SFLT1 is the bad angiogenic marker, which is representative of endothelial damage, and PLGF is protective. So I'm really not going to go into the nitty-gritties of this because ultimately we have to understand how we probably use these markers for prediction and prognostication. So what happens in PE? Can somebody just answer this question? If there is preeclampsia and there's endothelial damage, what happens to the SFLT1 PLGF ratio? Why should it increase? Because the numerator increases and the denominator is less, relatively less. All right? So, and then we have to understand, do we have a single cutoff, or we're going to have gestational age specific cutoffs, or are we going to have the plurality based cutoffs? Because we can have singleton pregnancies, we can have multiple pregnancies, we can have different gestational ages. Yes, we do have gestational age specific cutoffs. In fact, we've heard about these studies. I'm just trying to give you a glimpse of a summary of what we heard in the morning. We've had two kinds of studies. One is where we're taking a cutoff from 28 to 34 weeks of gestation, where we're taking something like 33 and 85. 33 is the lower limit and 85 is the upper limit. And anybody who's above 85 is dangerous. And when we're looking at after 34 weeks, it is less than 85 and up to 33 and 110. So that is the cutoff. And the sensitivity that we are actually working with is somewhere around, say, 82 to 86%, but the specificity is very, very high. It's about 97% when we're looking at these cutoffs. Yes, ma'am. I'm actually coming through the studies again, and I'm actually going to tell you this. And the other important thing is we also have this prognosis study where we're having a single cutoff, where we're looking at 38 as the decision maker. So if you're looking at somebody who's less than 38, she's safe for the next 1 week. But if she is above 38, she can develop preeclampsia in the next 4 weeks. That's the understanding. So that is something that you have to work with. That's why I'm trying to tell you, because I'm going to take you through the studies again. But when I'm going to discuss the cases, you should understand what I'm trying to tell. So basically, you understand that we are trying to map the root cause of disease. We are not going to do consequence management. We are not going to map consequences like urine albumin or uric acid. They're all endpoints. And we are going to actually look at host response to endothelial damage. And that is nothing but the SFLT1 PLGF ratio. This is what we're going to do. And what are the cutoffs? Madam, because we have to work with those things, 28 weeks onwards. Actually, there's not been any standardization. And as Dr. Sarosh Rana rightly pointed out, you can have predictors of preeclampsias, one-time prediction, which happens in the first trimester, but you need to add on uterine artery Dopplers and maternal characteristics. But preeclampsia is a progressive disease. So what they say is it's better to prognosticate every 2 weeks, probably till delivery. So if you're looking at progressive and serial surveillance, SFLT1 PLGF after 28 weeks does better, but we've had studies to say up to 24 weeks where we've had cutoffs. We work with the same cutoffs up to 24 weeks, where 33 and less is dangerous. 33 to 85 is the intermediate group. Above 85, 33 and less is normal, and above 85 is dangerous. And when you're looking at 34 weeks till 37 weeks, it is 33 and less and 110 and more. Beyond 37 weeks, we cannot use the biomarkers. So that's for the broader understanding. And what is very important is most of these biomarkers turn positive about 2 to 5 weeks prior to the onset of disease. So that gives you that valuable time to risk modulate. So one of the commonest questions that most of the clinicians ask me is, you did a biomarker, it is positive, so what are you going to do? So what I'm going to tell them is I'm going to do more surveillance, and improve the outcomes. So what is that surveillance? We have to customize solutions because preeclampsia could be because of multiple factors. So you will have to stratify, like how Dr. Sarosh Rana actually mentioned in her lecture, you cannot keep doing surveillance on every woman. Even if she is hypertensive to start with, you must understand who is the dangerous variety and who is not. And for that, I need to have a basis. And I need to have a test which has got a very good sensitivity and specificity, which could be probably used to predict an adverse outcome in her. She's not interested to know whether she's got preeclampsia. What she is interested to know is whether she's going to be sick and whether she's going to have a sick baby. So preeclampsia is just a nomenclature. So with this background, so do you have any questions? Can we interpret these cases using the SFLT1 PLGF? I'm going to give you some actual case scenarios. These are our the study recruits. In fact, we are doing the collaborative study with the Maternal Field Medicine Chicago on the biomarkers. This is real-time prognostication and prediction with biomarkers. And all these are our study recruits. Now, the first case is a typical rule-out case. Now, it's not difficult. Let's just analyze this, and you will answer, and let me do the biomarkers after that. She's a 26-year-old primigravida who's married for 5 years. She's ANA positive, extended profile. She was investigated for ANA because of her fertility issues. She was a known case of over DM on diet. She was TPO positive, so she is autoimmune, subclinical hypothyroid on thyroxine supplementation with history of subchorionic hemorrhage in the first trimester. The NT scan showed a mean uterine artery PI of 2.3, and then she was investigated for APLA. That was because she was a difficult conception, and she was ANA positive, just like what we were discussing, and the uterine artery PI was sky high. The beta-2 glycoprotein antibody just turned positive. She was IgM positive, And she settled immediately with low molecular weight heparin, which was enoxaparin, which is given for 40 milligrams subcutaneous once daily, and immunomodulation with steroids. She was secondary APLA, actually. And she was given Vizolone 5 milligrams BD with HCQS 200 milligrams BD. So what happened at 20 weeks? Her baseline platelet was normal. It was more than 1.5 lakhs. I have really not put this in the slide, but it was normal. Because we always do CBCs every trimester. And after starting heparin, we repeat it after a week to map hit. So it was normal. At 20 weeks, when we did the anomaly scan, rest of it was normal. The scans, the PI settled. I didn't put it because it was not significant. It was normal. It normalized after the low molecular weight heparin. At 20 weeks of gestation, SGOT, SGPT was incidentally slightly high. It was 37 and 60. Are you worried at 37 and 60 SGOT, SGPT at 20 weeks? And a platelet count of 98,000. Yes, I mean, I would definitely keep her on a surveillance when I'm looking at something like 37 and 60. And 98,000, I would do a repeat count just to make sure maybe it could be thrombocytopenia, APLA associated with thrombocyte, because she's beta-2 glycoprotein antibody, which is very, very commonly associated with thrombocytopenia. The abdominal scan was done because there was a slight elevation of liver enzymes, and it was within normal limits. But ecosprin was stopped because her platelet was less than 1 lakh. So she continued with heparin. She didn't have any spontaneous bleeds. And uterine artery Doppler mean PI normalized to 1.37 from 2.3. She was incidentally of low BMI. She's something like 42.5 kgs at 20 weeks. And the fetal growth was normal, and there was no obvious defects. This was at 20 weeks. Then she went away to Bihar to return after 6 weeks. Then the scan was done for fetal growth, well-being, and then extended defects. There was no extended defects. Then, incidentally, I had to look at the SGOT, SGPT because she came to me after 6 weeks. It was 204.97 units per liter. That's when I called sir and said, sir, it's 204.97. And then we did the rest of the LFT. It was perfectly normal. There was no evidence of hemolysis. PT-INR was within normal limits. I did the infection screen again. I did her HbSAg, HCV, hepatitis A. It was all within normal limits. We did the PET profile. It was normal. She was 26 weeks. But then I didn't want to lose time before I got my I also sent my autoimmune hepatitis profile, but it will take at least 2 days for me to get all the reports. So I started her on UDCA because she was sky high on the liver functions. Her PT-INR was normal at this point of time, which I have not put here. Incidentally, she turned positive for the anti-Smith antibody. That was the answer. She was TPO, she was ANA, she was anti-Smith. She was something like a mixed connective tissue disorder with hepatitis, APLA, thrombocytopenia. Very, very complex. Prophylactic steroids, betamethasone was given for fetal lung maturity at 28 weeks. I did put her on a surveillance. I didn't put in all the values. We did weekly LFTs. We did. What was the platelet It kept above 80,000. I'll tell you only the crucial platelets. I'll show you in the next slide. It always remained above 80,000. She's still pregnant. And the last value that I did 2 days prior was 78,000. Her INR is 1.07. Her SGPT is 615. And rest of it is normal. LDH is 165, uric acid is 1.3, and now I wouldn't give up the biomarker. So what do you think her biomarker is? I counseled her. It is very difficult for me to tell her what the biomarker was, because making the patient and the couple understand, because the cost of the test, she's not going to be in my study because she's not hypertensive. And the cost of the test is 2,400 rupees, and I'm battling maybe growth restriction, bad platelets. Taking out a baby so early is going to cost her an ICU. So I told her, 2,400 rupees is worth it. We'll do it. When we did the SFLT1 PLGF at 28 weeks, it is 3. So are you happy or not happy? So it's a rule out, isn't it? So what did we do next? We kept monitoring. We had a surveillance protocol. As far as the fetus was concerned, we did modified biophysical profiles every week. Then there was this oligohydramnios, which is actually kind of set in now. And then we started doing it twice weekly. We did the growth scans every 2 weeks. Then we monitored with LFTs every week and platelet counts every 3 days. In fact, I did the LFT and platelet count every 3 days and PTINR every week because they remained stable. Platelets were always above 80,000, kept within 1 lakh. She was out of ecosprin. She was on UDCA. Her abdominal scan was perfectly all right. INR, the last INR was 1.07. But I was happy because I did do the PET profile also just in case, but everything looked normal. And the SFIT1 PLGF is absolutely normal. And the couple is also convinced that, yes, we did the right thing by continuing. The baby is fine in spite of 9.9 AFI. The Dopplers are perfectly all right, but I'm seeing her literally every 5 days. So did biomarkers help rule out atypical preeclampsia and endothelial dysfunction and help? She's pregnant now and help prolong pregnancy. She's 32 weeks. Sir asked me, how old is she in pregnancy? I said 32 weeks, sir, but I want to give her 34 weeks. She's 1.5 kgs, but I don't know what her platelet counts are going to read tomorrow. So did it help me rule out atypical preeclampsia? Yes. So this is one rule out example. So we have some of the rule in, the very, very dramatic experiences with Dr. Sushma would actually start off. Then we would interpret, yes. I advise. Yes, that's the next thing that I can think of, isn't it? If I'm looking at very high liver enzymes, and when I know that she's not infective and she's not AFLP, then the next thing that I have to probably look at is autoimmune hepatitis. So, and that is commonly associated with anti-Smith. She's not exactly, I have not put in what autoimmune she is. She is some mixed connective tissue disorder, but she's definitely autoimmune hepatitis.
No, what happens once you get a low platelet count, you'll automatically do a liver enzymes. Now, once the platelet counts are low and liver enzymes are high, the first thing that strikes your mind is that it's a HELP syndrome. Yeah. Okay, but she had very good clues. Uric acid remained normal, LDH remained normal. So now the confusion starts. What is it due to? Is this patient going to land up with AFNL, or is this patient going to land up with HELP syndrome? Are we dealing with some kind of a TTP? So in this case, when the biomarkers were done, the ratio was absolutely normal. Not just normal, it was very, very reassuring. So obviously we had a good rule out. Supposing, let us say for argument's sake, we wouldn't have done biomarkers,
You're scared.
then you're worried.
You would have.
You're definitely worried to continue. Maybe we would have delivered her at 28 or 29 weeks.
When the baby is 1.3 kg. Growth restriction has set in, but that happens in autoimmune cases.
There's a holding on.
Yes, ma'am. That was expected. But she's beta 2. She's beta 2.
See, the hydrocortisone, I think she was getting Visalone. Visalone is not a good steroid for RDS prophylaxis. So we have to give the regular RDS prophylaxis.
And in fact, I upgraded Visalones. I didn't upgrade Visalone. The prophylactic dose of Visalone is 10 to 15 milligrams per day. It's not the therapeutic dose. Therapeutic is 1 milligram.
1 milligram.
So when I started with 5 milligrams BD, she didn't have growth restriction and she was low BMI. So I kept her only on 5 milligrams BD, but when there was growth restriction, that is when I upgraded steroids, because we should not cause unnecessary harm also. And then the liver enzymes kind of settle, but still fluctuating, but it's not going beyond 600.
She was a GDM.
I'm monitoring and she's on diet. She required insulin during the phases of betamethasone, but we can probably handle the sugars and still keep her on this. No, she's not.
Negative. Extended is negative.
Extended profile was done. It was all normal.
So we go on to the next case.
It's a rule in case.
It's a rule in case. The previous one was a rule out case. So it's a 29-year-old primary IUI conception. She was hyperhomocystinemia, hypothyroid. So there is endocrine problems. Diagnosed to have gestational hypertension at 24 weeks. Was stable with normal PT profile and BP ranges with tablabertalol 100 mg TID. And since she was hypertensive and she was counseled for SFLT PLGF at 28 weeks, At 28 weeks, her first value of SFLT PLGF.
You may be surprised as to why we did the split-1 PLGF at 28 weeks. And that was because she was part of a collaborative study. So we had counseled her that we would probably include her into this study, and we would do serial surveillance. We include all hypertensive singleton pregnancies after 28 weeks, and we do the split-1 PLGF for prediction and prognostication every 2 weeks. So let me just tell you what we do in this study here only. So between 28 to 34 weeks, along with the PET profiles, we do the split-1 PLGF. Suppose the split-1 PLGF is less than 33, she automatically comes back after 2 weeks for repeat testing, both for maternal and fetal parameters. So we do the PET profiles, we do the split-1 PLGF, we do the fetal profiles. It won't change. But suppose, no, this is at 28 weeks.
24.
She was part of our research project.
24, she was
they come into
diagnosed
protocol.
as-
So they get it free. Before 28,
She's
the
part of
previous
the
patient
study.
had to pay because it was earlier.
Here it is serial surveillance. You're mapping the disease. So incidentally, she was gestational hypertension. She was singleton. She was diagnosed at 24 weeks. At 28 weeks, she got the first biomarker, and it was scary.
So what is the value like?
See, she's 28 weeks and she's 84.6. So what is
Not
that?
happy.
So
Not you, Dr. Sunita. You're part of the biomarker workshop. So we're not giving you any marks for that. What kind of high? It's the intermediate category, isn't it?
Intermediate or high?
It's still less than 85, so 33 to 85. So, but if you're looking at the prognosis trial, it's something like 38 and above is definitely serious. So she is going to have a risk in the next 4 weeks is what prognosis says. So now let's see what happens. The next slide.
So at 29 weeks, patient presented with worsening edema and fluctuating BP readings
This is exactly after a week.
after a week. And in the background of PET profile, a turbulent
It was a serene PET profile and a turbulent.
A turbulent repeat SFLT PLGF. See, once it's intermediate, it comes within a week's time. We repeat the SFLT PLGF in a week's time. So the repeat SFLT PLGF was 164.
What
so
is
what does
important?
it say? It's
Most importantly, the question by most clinicians, just repeating PET profiles may not mean anything. You might just get a small rise in uric acid, but it may not tell you that she's sick. But it's absolutely okay. I mean, the PET profile is not bad. Maybe a 4.3 uric acid, a platelet count of say 1.86. It's not really bad.
Her PET
But when her
profile
split-1 was repeated because she was intermediate positive, she was 164. That just rings the bell. She's progressive. So you need more surveillance. See, you cannot prevent complications in preeclampsia. You can only postpone it or maybe have it in a place where you can attend to it. So that's how you prevent morbidity, mortality. And that is what SFIT1 PLGF does to the clinician. It tells you this is the person that where you have to probably do surveillance.
So we upgraded on our antihypertensives because her BP was fluctuating, and she was kept in-house for a
We locked her in the hospital and looked at her BPs.
So she had a close maternal-fetal surveillance. So Doppler studies, on a serial Doppler studies, it showed reduced diastolic flow in the umbilical artery at 31. So we started from 28 and she's reached 31 weeks with the surveillance. With progressive Doppler screening, we went up to 32 weeks 4 where there was reversal of umbilical artery, patchy reversal of umbilical artery Doppler. That's when we decided for an emergency LSCS and delivered a 1.9 kg girl baby.
Actually, the maternal profiles have not been included. She also went high on the labetalol requirements. She went on almost like 200 milligrams TID. And with that, she had bad fetal Dopplers. And this actually just was an example of the prognosis
Her
data.
PET profile
So
till
she-
that point was all normal.
But she got a 1.9 kg, which probably she would have not got, or maybe she could have been subject to risk like abruptions or IUFDs if we didn't do the surveillance. And the advantage of doing serial surveillance is I'm mapping her every week. So I know exactly what's happening to her. A 12-week prediction or a 20-week prediction will not help me with telling me how the disease is progressing. So I'm actually customizing treatment. So this is, so with the biomarker, we did a rule-in and maybe improved. The mother didn't have any problems. We monitored her. She was on antihypertensives for 2 weeks and got out. She didn't require any blood transfusions. It was an uneventful, little bit of hemorrhagic cesarean section, but otherwise nothing major. And the baby was fine. It lived in an ICU for about 4 to 6 weeks. So 4 weeks and then 2 weeks for nursing, and it came out, so it was not a problem. There was a little bit of a hypoxic insult at 1.9 kgs. Then we have another dramatic case. This is also another inclusion into the study.
She is an elderly 46-year-old IVF DAM conception, donor embryo conception. Known case of chronic hypertension on labetalol from the first trimester on a 100 mg BD dose, over diabetic on insulin with subclinical hypothyroid on thyroxine. So she's loaded with all the disorders. So abdominal scan were within normal limits. Bloods, fundoscopy, ECG, echo was done because of considering her age and other risk factors. Was monitored with regular home BP and blood sugar monitoring and twice monthly antenatal visits. Routine antenatal scan, NT, anomaly, fetal echo, all within normal limits. So going well till now.
It was normal.
Was normal. Scans were normal. So was upgraded to labetalol 100 TID at 24 weeks in view of slight fluctuation up to 150-100. And the patient was stable with a normal bloods with a fetal growth restriction. There was a fetal growth restriction and bilateral uterine artery PI was 1.1. So that was normal. At 28 weeks, because of the background risk
She was
factors,
also into the study.
we
She was
had,
sailing smooth. 28 weeks and then came the problem. It was
So,
155. So are we happy? This was not, she was absolutely fine.
Normal.
We had
Because-
upgraded. I mean, there were some clues. The LDH was slightly on the higher side, but it was not that, it was so drastic. But she just walked in and we did the 28-week test and it was 155. So what did we do, Sushma?
So she was monitored again. So 158 it says high risk. So she's going to be on surveillance, a close surveillance.
On
So-
the same day, actually, she was counseled for admission. She didn't agree
She
for
didn't agree
admission.
for the
We
counselling.
counseled her for betamethasone. She said she would come after 2 days. Consents were taken. Then we did a growth scan on the same day. It showed a lag of 9 days with expected fetal birth weight at 900 grams, which was 15 centile. This was after the 24th week scan. Fetal Dopplers were within normal limits. And then she called me again after 2 days and she said she has, what did she have?
Decreased fetal movement for like 12 hours. Since 12 hours, fetal movements are pretty slow.
She's 29 weeks.
So she's 29 weeks. So repeat bloods. So LDH showed 486 units per liter. Platelet showed a drop of 1.6. Urine albumin 1 plus. Fetal Doppler showed absent flow on umbilical artery Doppler and redistribution on MCA. And DV was normal. Fetal movements appreciated on scan, but they were sluggish. No obvious retroplacental, any fresh abruption, retroplacental hemorrhage.
Scans are never sensitive.
Never sensitive. So, and like a normal. So CTG showed small spontaneous deceleration, not in labor. Hence, counsel for rescue dose of steroid, betamethasone, and patient scheduled for an emergency
She
LACS
came
post
with
steroid.
abdominal pain, brownish discharge, decreased fetal movement, 160, 110, 155 on the biomarker, sluggish movements on scan, Doppler changes. I just had to call the neonatologist, but thankfully the couple were very, very cooperative. They did whatever. Yes, I mean, it was the last best chance, sir, and the baby is absolutely fine now. The baby is 18 months old. We are supposed to follow this baby for at the end of 1 month and 1 year. So at the end of 1 month, the baby is fine, and at 18 months, the baby is about 8.6 kgs and doing well, actually.
So this was a rule in case. In this patient, introp.
Introp, did you say? Yeah.
Introp, there was 200 ml of blood clot noted after delivery of placenta. Placenta
bad
showed
placenta.
necrosis and calcification. The baby was delivered with Apgar of 6 and 8 at 1 and 5, weighing of 875 grams. And the rest was told by madam. So baby was transfused to Paxil because it appeared anemic and stabilized in the NICU for 9 weeks and now 18 months.
But this is the last best chance, and we did everything we can, and probably biomarkers helped to rule in. We didn't repeat it more than once, but she got the baby. And that was an abruption, actually. I think this is something that I've discussed several times, actually, because it's never obvious on scan. It's just a slight deterioration in the clinical condition, but it's so typical. But the biomarker gave me that confidence to tell the couple, no, you're serious. Because sometimes the clinician is not very confident to, maybe or maybe not. But if I had an IUFD on my head, I would have cursed myself. Ma'am, actually, I didn't have time. It was just,
Abruption,
she
myself.
just bled. It was clots. And after about, I just gave the steroid and took her to the OT. And the baby had bled. There was 200 ml of clot. It was very dramatic. And the baby was transfused blood. We didn't have an in-house NICU at Milan at that time. I mean, we can't stabilize these kinds of babies. So we just had to shift it on the ventilator.
So going on to the
Did biomarkers help avert IUFTs?
Yes, no.
Yes.
been better.
Yes. But at least she agreed
But
for a
because of the-
C-section, ma'am.
Because of the counseling, she at least had that
No, maybe-
sensitization to come back soon.
The thing was, she was sure that her BP was 140/90 and it was just showing on scan. She said she'd come back on Monday. Yes, ma'am. That is very, very correct. Okay,
So
then we
going
have another rule in Sushma.
Yeah. This is a rule in case. She's a 27.
She's a rule. We are giving you
Rule
rule
out
out.
case.
Are we?
Case.
Do you feel that we are doing unnecessary interventions because of the biomarkers? Does anybody feel that we're doing iatrogenic preterms? I want your opinion on that. I mean, be honest. If you feel that we're doing unnecessary cesarean sections or we're delivering babies because of the biomarkers, see, as per the study, we are not supposed to interfere because of the biomarkers. But incidentally, we are so tied up with the patient. There are so many clinical features which turn up after the biomarkers, which prompt you to do the right thing. But it's not because of the biomarkers. I didn't section her at 155. So, do you feel that? Now, we're going to show you examples where we prolong pregnancy because of the biomarkers.
So she's a 28-year-old, Gravida 4, Para 1, Living 1, Abortion 2. She was LA positive on low molecular, prophylactic dose of low molecular weight heparin. She was TPO positive, hypothyroid on thyroxine supplementation, over diabetic on insulin, was diagnosed with chronic hypertension at 16 weeks, and was on labetalol 100 mg BD. Bloods were normal. NT scan at 13 weeks showed a very high PI, and the right uterine artery showed 2.3, PI of 2.3. That too on one
Scary
side.
because we
and
were
the
not able
other-
to measure the PI of one of the arteries.
And there was high resistance in the left with absent flow. Hence, the PI could not be measured on the left side. Hence, upgraded to 40 mg, low molecular weight of 40 mg twice a day. So,
Risks were explained to her because it was a very bad uterine artery PI. Obviously, we're not going to map her for anything else. I can't do the biomarkers. I can't talk about growth restriction. I'm going to tell you about the obstetric history. It's very scary.
it's coming in the next slide.
Yes. So with that, she weighed about 90 kgs at delivery, ma'am. She must be between 28 to 29. She's not obese, but. So she's overweight. And what happened was, I told her, I mean, the uterine artery Doppler is really bad. And the only thing that we could, her sugars were well maintained, her HbA1cs were good, the thyroids were under control. The only factor that maybe we have to probably map, because she had a history of IUFD at 24 weeks, and an early preterm delivery at 32 weeks with a missed abortion. So with this, she definitely has a progressive placental disease. So we upgraded to therapeutic dose of heparin with full consents. So this is what we have to do when we have a marker positive. If you don't interfere, just do the markers will deteriorate and the patient will deteriorate. So you have to risk modulate in between.
So by 19.
Yes, ma'am. She was on ecosprin. And she's on heparin also. And she was upgraded. Yeah, she's 40 milligrams PD.
So at 19 weeks, uterine artery PI almost normalized to 1.3. Was followed up twice monthly visit with regular BP, sugar monitoring, and appropriate titration of insulin and thyroxine supplements. Combined test, anomaly, fetal echo were all normal. So now was counseled for serial monitoring with.
She was chronic hypertensive. She got into the
with
study.
She got into the study, hence she was serially monitored with S-FLARE PLGF every 2 weeks from 28 weeks onwards with.
Yeah. Now take them to the obstetric history very slowly.
Yeah. So obstetric history is there was a previous one IUFD at 24 weeks, one missed abortion at 8 weeks, one severe growth restriction with iatrogenic termination at 32 weeks for worsening fetal Doppler. It was a 1.2 kg boy baby, was stabilized in the NICU for 3 weeks, doing well.
Haven't
So-
we encountered such cases? And we also
Bad
have
obstetric
some
history.
we also have some telltale evidences to say, yes, if you have had a IUFD at 32 weeks, deliver them at 34
With
weeks. It's so
34.
arbitrary. Are we justified? So what did we do next?
So, okay. So we did the SFLIP PLGF was performed 5 times because she was in the study, and every 2 weeks we do it. And the values always range between 4.2 to 7.6.
That was the
So that
lowest and the
says-
highest.
Yeah, so that says it's normal. PET profile within normal limit except for the platelets, which showed a downtrend.
That was the special effect after 34 weeks. The platelets started fluctuating. I discussed with Dr. Prakash Mehta. I mailed Dr. Sarosh Rana. I was a little worried about the alkaline phosphatase. There were small papers saying that,
Borderline.
yes, it could be associated with
With
abruption.
abruption.
There was this, I had delivered her previous baby without the biomarkers, and it was 1.3 kgs at 32 weeks with bad Dopplers and retroplacental hemorrhage. So am I doing the right thing? So the answers were, if the biomarker is good and the rest of it is normal. Sir also felt that alkaline phosphatase may not be the only thing. It didn't climb up beyond 510 to 531. So we did crawl every 2 weeks and then reached the 37 weeks mark. There was growth restriction,
Which set in at 34.
but it was still okay.
Okay, 15 centile. So went on with elective LSCS at 37 weeks.
And lo and
given
behold, she was
2.3.
discharged at 3 days with the baby
No
home.
NICU.
And she was one of the champions of the SPLIT1 PLGF trial because the baby lived for 6 weeks in the NICU last time. And we had kept her in the ward for more than 2 months. I mean, she was, Deepa Prashant was in, she was like 2 months in the ward, and it was really tough. So this helped us. She, at the end of 37 weeks, she had tears in her eyes because she never even dreamt she would go to 37 weeks with an IUFD at 24 weeks previously.
So this was a rule out case.
So the next slide. Did biomarkers help to prolong pregnancy judiciously and avert iatrogenic preterm birth and fetal growth restriction? Did it? But the baby is... Okay. Then we have the last example. So this is a very, very straightforward case, isn't it, Sushma?
Yes, it's again a rule out. So
This is a rollout again.
yeah. A 29-year-old primey, known case of GDM on insulin, diagnosed as gestational hypertension at 33 weeks. So she was not included in the study and was started on labetalol 100 mg twice daily. Was counseled for SFLIP PLGF, serial monitoring along with conventional PET profiles that remain normal. No growth restrictions on scan, modified biophysical profile done once in 2 weeks, and was good with interval growth every 3 weeks, which didn't show any compromise. So SFLIP PLGF at 34 weeks and 36. So we do it
She
only till
was-
36. She was only recruited at 33.
She had bigger values, but still they were normal.
She had 18 and 26. There were only 2 tests done, so and it was screen negative. She was monitored, and post 37 weeks, patient was on bi-weekly follow-ups for bloods and modified biophysical profile with regular BP and sugar monitoring. Was all normal up to 39 weeks. Was monitored till 39. We just waited on for the good bishop score. So was induced and delivered at 39 weeks 2 days. It was a 2.9 kg girl that was good with a good upgar and full-time vaginal delivery. Post-delivery BP normalized, discharge within 2 days.
It's not to advocate a vaginal delivery, it's just to say that she was safe at 39 weeks. And incidentally, her bishop's score was also good. And she was the late onset, she was gestational hypertension after 34 weeks, so she is not going to be preeclamptic. But how many times do we decide at 37 weeks in such women because ACOG recommends it? How many times do we do it? So beyond 37 weeks, what do? We have to monitor her without the biomarkers. So what? We know the biomarker is normal, but then call her every 3 days. It's still worth it. But at 39 weeks, give her a birth plan if she is absolutely safe. So this helped us to rule out again. So we didn't have an iatrogenic prematurity.
So did biomarker help us to get beyond 37 weeks safely and allow a vaginal delivery with better bishop score?
So these are our study recruits. Now, You want to know more about the study, isn't it?
There is one more very important case where we can do, because quite often, patients do not have risk factors.
Correct.
They're simple primary gravidas, and at 34 weeks, the BP just touches 130/90.
Exactly.
Albumin is traces.
Yes, sir.
Now, because I get a lot of these referred cases, the obstetrician who has seen the patient reassures the patient, no, don't worry, you have no urine albumin, your BP is only 140/90. 2 days later, the patient comes with convulsions.
Correct.
And when they land up with me, the first question they ask is, why didn't our doctor recognize this before?
Correct.
Now, here we have a test. Possibly, if that
Yes.
done at that 140/90 SFLT PLGF ratio,
Yes.
they would have found that it was abnormal. Probably they wouldn't have sent her home.
Correct.
Kept her in the hospital, monitored her,
Exactly.
and avoided this kind of questions.
And maybe should
from
have
the
got
patient
a
and
little more
relatives.
time, sir. Maybe 2 or 3
She would have got
weeks.
more time also.
You would have started her on antihypertensives.
Absolutely.
Yes, sir. And there was a point which was made very clear by Dr. Sarosh Rana. If you have a clinical, in fact, the idea of going beyond hypertension, because hypertension comes with so many medical problems. So are we justified in doing biomarkers in high-risk pregnancies? Because most of them have endothelial damage. So this is an extrapolation that we want to take it forward beyond hypertension, sir. That's happening. And whenever there is a clinical suspicion, you are justified, sir, to do it because you have a basis. And in Europe, people are doing it, sir.
Absolutely, because otherwise you don't know. Her PT profile is going to be normal, her albumin is going to be, let's say, just traces, nothing. So
And
great.
her NICU is going to cost much more than 2,400 rupees.
Absolutely. Absolutely. More than anything, you lost a patient, no? Because the patient was referred to the tertiary care center.
Yes, and an emergency management is usually a knee-jerk response rather than a
Absolutely.
planned event.
Planned event.
Yes, sir. Yeah. Oh, that's a huge discussion, actually. See, if you're having the combined test, it's only about prediction of early onset preeclampsia, one-time test. Okay, but the question asked by the patient is, you're telling me I'm going to get preeclampsia, but what are you going to do with me? Are you going to just say your 12-week scan is normal and just treat me the conventional way? No. When you found it, then you go beyond 20 weeks and map the disease for her. And then risk modulate. So don't stop at just 12 weeks prediction. Go beyond it. Map the disease till term. That's what Dr. Sarosh said. Go up to 37 weeks because you don't know where you're going to get into problems. But most of the time, the ones who are not marked never reach 37 weeks.
How often do you see normal ratio next 2 weeks suddenly jumping up?
We've had sudden jerks, ma'am. With monitoring, no. That's why we've had this protocol where we've actually taken in like 2 weeks. And then if she's intermediate, we catch them again at 1 week. So 84 becomes 165. But we've had those immediate responses, like one-time tests. Dr. Sunita, 3 days ago, she had a case where there was severe fetal growth restriction. One time came to be 566. So we didn't really, actually I have a chart on the prognosis study which says, whenever you have somebody who is more than 600, she is going to have a problem within the next 48 hours. So if you have somebody between say 110 to that, then she's going to have it maybe in the next 1 week. And if you're going to have it between 80, that is between 34 to less than 34 weeks. But if it's safe, it is safe for the next 4 weeks.
Most of the angiogenic markers actually rise because of more of placental ischemia.
Yeah.
So
Progression.
it gives you an idea as to how much ischemia is going on.
Exactly.
And ischemia is not going to suddenly jump.
Yeah, it's a
It is going
process.
it's a process.
But if you don't see them for 2 to 3 weeks,
Yeah,
you
no,
cannot,
no,
I mean,
Absolutely.
you will end up with the problem. So you have to be way behind them actually. But you know which are the ones where you can filter out, madam. Now I'm actually taking all hypertensive women. But once she's positive, I will not repeat the test because it's not cost effective. I will not be funded for that. But you can still map. In Europe, people have mapped beyond 155, found out that point where she had preeclampsia real time. So that is where they found that at 650, she threw a fit. Or she was into a problem.
So you all never repeated it?
No, we didn't. But when they were negative, we did. Because the study allows for it, we have the ethics committee approval.
How much of time did you all have after it became high risk?
4 weeks maximum.
But you didn't repeat during those
No. But that was a question which we kept asking Dr. Sarosh, but we don't have permissions for that in the study. Because you know it, and you're not basing it on the biomarker. So what is the basis to repeat it again? Because then you will have to do another kind of study, ma'am.
The second case was like 5 weeks prolongation.
usually 4 to 5 weeks, not more than that. So can I just go through 2 important studies after this, just to make sure we get the right messages? Yeah. So this was just tell you that we graduated from the PLGF experience. We initially did the PLGF study, this was way back in 2013 actually, where we just did PLGF in all high-risk pregnant women between 20 to 24 weeks. And we based it on the Pelican study, which was popular in the UK at that point of time. And anybody who was less than 12 was serious, and anybody who was between 12 and 100 was the intermediate category, and above 100 was normal. We also had gestational age-based cutoffs using Allier inserts. And we had some very good results. In fact, we were working in a tertiary center where most of the pregnancies were high risk. And the results, I'm just going to summarize because it's a big study actually. So it was a single center trial. And ultimately what we did was it helped us to predict preeclampsia in thrombophiliacs with a p-value of 0.065, and in the hypothyroid cohort with a good p-value of 0.069. So, and the other advantage that we got in this study is the biomarker was positive in the cohorts with uterine artery Doppler being screen negative. And some of them were, that was almost 45% of the cases, and most of them were their own historical controls. I had a couple of examples. I had 2 ladies who had IUFD previously, came back to us pregnant again, and with the biomarker we went up to 28 weeks, gave them a viable pregnancy. So that is how the power of the study improved, because they were their own historical controls. But what was very, very important is after the test turned positive, we just got 6 less than 12s. But after that, after the test got positive, we effectively improved the lead time to delivery. So we got something between, say, 4 weeks to 7 weeks. We went even up to 9 weeks. But those were the varieties without hypertension. So this was not related to hypertension in all cases. So ultimately, we prolonged the lead time with biomarkers, gave them a viable pregnancy. But this was the PLGF experience. There were some fallacies in the test because we included multiple pregnancies, and they never really actually matched what they, because there was never synchronizing things, because people who were negative had preeclampsia. That was one problem. And the second thing is we didn't do serial surveillance. We just did one test, and then we had to just go around looking at people beyond that, because hypothyroidism in the sense they were autoimmune. I have really not dissected on the TPO positivity, and some of them were also ANA positive actually. But when we looked at the hypothyroid cohort, there were several tables that were drawn. Hypothyroidism predisposes to hypertension. That cohort with the biomarker positivity predisposed to severe early onset preeclampsia with a better p-value. And most of them, actually when you look at the study in detail, they were all TPO positives actually. So they had an autoimmune association. And there was another important thing. People who were thrombophiliacs, they have their uterine artery Dopplers absolutely normal because they're already uterine artery Doppler. They are risk modulated. They come to us pregnant with low molecular weight heparins, but then at 24 weeks you're struggling. That is, then there is progression. That is when you have to map the endothelial damage, not the vascular perfusion actually. So that is why in thrombophiliacs it's got a very, very beneficial value. So this is what, but then we had to discuss it out. I actually put this in the ISOM forum. This is when I first met Dr. Kanumanchi and Dr. Sarosh Rara. There was a lot of discussions on it. And they educated me that it was not PLGF, it's the SPLIT1 PLGF, because I was not measuring the host responses. They told me that there were several instances where SPLIT1 was relatively less compared to PLGF, and the patients did well, so I was not measuring the ratios. Then is when I graduated. So it was a process. Then from 2012, we worked for about 4 years. In 2016 is when we got, for 2 years I worked with the idea with Dr. Sarosh, and then we evolved into the collaborative research project in 2016. And now we have 33 recruits. So this is how it is. Now these are different papers. I have so many papers which will just tell you what is the importance of doing the SPLIT1 PLGF. This is a paper which came in 2016. SPLIT1 PLGF helps, see, a comparison of the diagnostic utility of the SPLIT1 PLGF versus PLGF alone for the detection of preeclampsia. The fully automated ELIXIS immunoassay SFIT1 PLGF provides improved diagnostic utility over the triage PLGF with improved specificity, very important, for the clinical management of pregnant women with suspected preeclampsia HELP, especially HELP. So it did better compared to
HELP and
PLGF.
abruption.
Yes.
These two are very
Yes.
much related.
And this is something that came Spain does a lot of studies. I mean, Europe does a lot of studies. Dr. Oyer-Atika is part of these. So, not this study. I mean, he's been doing a lot of these APLA-related studies. So, this study said, this is the SFIT1 PLGF, said it can improve prediction of early onset PE for women at risk of the syndrome. So, we can use it at 24 weeks. There is a study by Stepan Holger where he has used it at 24 weeks. Then we have another study where we've actually looked at it for decision making, very important. In the UK, they use this for stratification. The NICE guideline helps them to rule in and rule out. So if you know that a patient is sick, just keep the patient in the hospital and probably look for problems because they feel it's better to manage them in the hospital than send them home. So what did they find out finally? The use of the soluble forms, soluble FMS like tyrosine kinase, the SFIT1 PLGF test influenced clinical decision making towards appropriate hospitalization in a considerable proportion, like what sir was telling, of women with suspected preeclampsia. This is the first study to demonstrate the impact of angiogenic biomarkers on decision making in a routine clinical practice. So it's very, very important for stratification. This is a very important study. I also happened to meet Holger Stepan. He is a great orator, a lot of clinical experience. This was in the ISSHP when I presented my poster. And he gave me some ideas about how to improve the recruits, I mean, the collection of data into the study. So according to this study, the maternal complications cannot be avoided completely, but women at high risk can be hospitalized. No data exists on the usefulness of the SFIT1 PLGF to avoid maternal complications. No randomized control trials, so that is what we need to do, have been performed to test the usefulness of the SFIT1 PLGF, and the test should be used in the population in which it is most reasonable, that is in the high-risk population, irrespective of hypertension. So the economics and resource utilization need to be considered too. So this is a perfect study, which is actually trying to tell us what we should be probably doing with the SFIT1. I'll just take another 10 minutes. I have some very interesting slides. Then we have this is another test to tell us that maybe SFIT1 PLGF is much better than doing just the PLGF alone. Okay, then the prognosis study. So this is something which Dr. Sarosh has also been telling. This is to make it easy for general obstetricians not to get confused with different cutoffs. So this was a huge study actually. If you look at, there were 30 study sites and 1,273 subjects enrolled. This was in Europe, and this was actually published in 2016. And what they wanted to demonstrate, that low ratios of SFIT1 PLGF predict the absence of preeclampsia within 1 week of baseline visit. Suppose it's negative, she's negative for 1 week. And to demonstrate the high ratios of SFIT1 PLGF, diagnosis within 4 weeks of the baseline. That is rule in. This is what they wanted to do. And there were so many secondary objectives. It's a big study, actually. So they also, the inclusion criteria was interesting. They had all these kinds. We had new onset elevated blood pressure, aggravation of pre-existing, somebody with hypertension and proteinuria. So anybody could be put into the study. And exclusion was manifest preeclampsia. They didn't want to do it. Eclampsia and HELP syndrome, because you'd already made the diagnosis, and you're not going to get the lead time. So finally, what they found, so it was the first study demonstrate that the SFIT1 PLGF ratio of less than 38 is useful for predicting the short-term absence of preeclampsia in women with clinical suspicion with a negative predictive value of 99.3, so you can send them home, and a positive predictive value of 36.7%. And SFIT1 more than 38 may help predict whether the pregnant woman probably may have preeclampsia in the next 4 weeks. So a single cutoff, this is what is actually advocated, of 38 for all gestational ages, simple and easy to use in clinical practice.
This is in all patients, not just
Yes, exactly. And even in clinical suspicion of a problem. So this was the summary, and I think this is an important slide. I think I have that slide last. Madam was asking me about what was that level which probably caused that problem, so I'll show you that slide. So this is an extrapolation. This we'd already started doing in 2016. This is what we did in our study. So just to make you very simple, what we did was we actually looked at all singleton pregnancies, all kinds of hypertension, chronic hypertension, gestational hypertension, any kind of hypertension, at 28 weeks, and repeated the test 2 weeks, every 2 weeks, along with the PT profiles. So we had gestational age-based cutoffs between 28 to 34 weeks. The 33 and less was normal. 33 and 85 was intermediate. Above 85 was abnormal. Beyond 34, it was less than 33 and 110. So we classified them as low risk, intermediate risk, high risk. And the ones who were low risk were sent home, called after 2 weeks for maternal fetal surveillance, along with the biomarker. But somebody who had a test positive, the intermediate variety, we are repeating the test again after 1 week. Somebody who is test positive, we will not repeat. We'll counsel for admission, do surveillance. And all these tests are not costed by the patient. This we are doing through the investigator-initiated study supported by Roche. And this has got an ethics committee approval from the IARH and the Maternal Fetal Medicine Unit, Chicago. It's a collaborative research project. And we have had about 33 recruits, out of which one is a dropout. I have analyzed it once, and I have also submitted another abstract right now. And this is the second analysis that we're doing. At the end of 50 recruits, we would complete this study because we've got some interesting inferences. This is what we presented in Berlin last year. So I'll just show you the results because of lack of time, and this is going into statistics. So this is what I said about the study. So if I'm looking at the results, 7 out of, this was on 21 women that we analyzed. 7 out of 21 women in the study group delivered beyond 37 weeks, as against none amongst the historical controls, 33 versus 0%. But there was one fallacy which was picked up because we had 1:1 historical control. So Dr. Karumanchi and Dr. Tadani was of the opinion that we had to probably increase the number of historical controls. So now we've increased it to 1:3 times. So so there have been some dilutions. 4 out of 8 hypertensive pregnant women with FGR delivered beyond 36 weeks, as against none amongst the historical controls. The study has slightly taken a turn in the second analysis. We had more iatrogenic preterms, but better salvages, but no IUFDs. So the study keeps changing as we are reaching the final target. 10 out of 21 babies in the historical controls were reported to have had prolonged stay in the ICU, as against 4 out of 21 in the study group. And there was no IUFD. This is something that everyone liked there, because there was no IUFD or neonatal deaths reported in the study group, as against 2. 2 is a big number in the historical controls. And there was 1 delivery below 30 weeks in the study group, as against 4 amongst the controls. And there was no significant differences in the number of patients with the diagnosis of PE in both in the control. That means we were doing it on a clinical basis and not based on the biomarker. So the discussion: serial surveillance with SFLT1 PLGF in hypertensive pregnant women in the 3rd trimester with appropriate risk modulation has shown a positive trend in prolonging pregnancies beyond 37 weeks. Prolonging the gestational age of delivery, even in fetal growth restriction with serial testing and surveillance, has contributed to reduction in prolonged stay in the NICU. Prematurity due to very preterm births was less in the study group with no IUFD or neonatal deaths as compared to the historical controls, who had slightly more very preterm births, along with 1 IUFD and 1 neonatal death, though the P values were not significant. So you have the onset of disease, which is the root cause of the problem. Look at the SFLT1 PLGF before the clinical symptoms, risk modulate, avert critical disease. This is the whole essence. Now we have Dr. Sunita. You may have questions. How do we do the test? How does the kit look? What are the prerequisites? So we have very crisp presentation by Dr. Sunita, who will tell us about the test.
So thank you, Dr. Revati. As we come to the end of the session, I'm sure we can go on and on with the case reports of all the SFLT PLGF. We are getting more cases, and then single values going high. We have reported more than 3 cases amongst those 33 cases. So single value high definitely proves towards the adverse outcomes. So illa correct agide, sorry. Okay. So future research, preeclampsia prediction with mid-trimester one-step test, SFLT PLGF. This is what we are discussing. Treatment to reverse the angiogenic imbalance, like what Sir was speaking in the morning. Neutralizing the antibodies against the anti-angiogenic proteins, that is the statins, use of these. Whether we can try all this is something which is questionable, but research is on in this aspect. Then coming to the methodology of testing, what you need is a 3 ml of blood. Since we will be testing the serum, we collect in a gel tube. It has to be centrifuged and has to be refrigerated. The sample remains stable for 48 hours. It is analyzed using the Roche analyzer, Alexis analyzer. And then this is how the report is generated. The
This is one of the recruits, the one that I showed you about the
yes.
NA positive lady. So this is how it is reported with a gestational age specific insert.
Yeah, we have the gestational age and the absolute values, and then yes, we have to see the ratio, and then we have the 50th centile, 5th centile and the 95th centile. But more than that, as we have already discussed, we have the absolute values for the cutoffs. So now coming to the what we should do in future. So as we all understand, preeclampsia is a complex multi-organ disorder. There is an imbalance in the angiogenic factors, and research is directed towards using the biomarkers for prediction and prognostication. And there are strategies at restoring the balance of these dysregulated factors. So these are the references, some of the references. And yeah, this is the final study that Dr. Sarosh Rana's study, which was already discussed in the morning. This was the conclusion. This clinical extrapolation of SFLT PLGF values in the hypertensive women may help prolong pregnancy beyond 37 weeks without increase in the perinatal mortality. It adds value by reducing the cost incurred due to the prolonged NICU stay. And of course, large studies are needed to confirm these findings. So this is the slide which all of us will have to understand. This is the important take-home message. We'll understand the slide from below. So like this is the cutoffs for the pregnancies less than 34 weeks and more than 34 weeks. As we have discussed, a single value ratio of 38 is the lowest threshold for the ratio. And if it is less than 38, preeclampsia can be ruled out within 1 week. Now between 38 to 85 in less than 34 weeks, consider follow-up every 2 weeks, 1 to 2 weeks. And preeclampsia cannot be ruled out, can be ruled out, but the women are at risk for preeclampsia. Between 85 and 655, 85 and 655, retest after 2 to 4 days to determine the trend. This is not part of our study, but this is what is recommended. Retest after 2 to 4 days to determine the trend, and diagnosis of preeclampsia is highly likely. After 65 value, it needs close surveillance. Delivery may be needed within 48 hours. So more than 34 weeks, less than 38 value, preeclampsia can be ruled out within the next 1 week. Between 38 and 110, it is suggestive of impending placental dysfunction. Current preeclampsia can be ruled out, but the women are at risk. So once again, you can retest if the value is more than after 110 up to 201. Retest after 2 to 4 days to determine the trend, and diagnosis of preeclampsia is highly likely. Above 200, later than 34 weeks, it is associated with the need to deliver within 48 hours. Yes. Keep repeatedly do the test so that we'll get to know where we stand. So this slide actually sums up the Yes. So this is it. Thank you. Any questions? I think we are done. So, at the end of the session, I would like to thank each and every one of you for making this session, for making this session much more interactive. I would like to thank all the delegates participating from the other center, Edapal Center. Doctors, thank you very much. Okay. Thank you very much, the Edapal Center.
Thank you so much.
Yeah.
Thank you so much.
Yeah, thank you. Any questions?
About that case number 1,
Yeah.
Dr. Revati ma'am's case number 1. That is a case of autoimmune disease where we are expecting antiplatelet antibodies.
Okay.
So, which might cross the placenta. So in that case, I think we should be more vigilant about in fetal thrombocytopenia too, right?
She was beta to glycoprotein antibody positive, and
Nuclear antibody.
she was actually done an antiplatelet antibody which was negative.
Okay.
So that is how we came into a conclusion. It was not shown on the slide. We came into a conclusion that she was thrombocytopenia associated with APLA. And she's remained at that level for almost 10 weeks now.
Thank you so much.
Sure.
So thank you, everyone.
We have Dr. Hema doing the vote of thanks.
I take this opportunity to extend our sincere thanks to all our international, national speakers from different destinations virtually. I must mention our deep sense of appreciation to Dr. Saroj Rana for sharing with us the biomarkers during pregnancy to prevent preeclampsia complications at our first oration. I also wish to express my gratitude to our teacher and mentor, Dr. Prakash Mehta, for supporting us and guiding to organize this conference very successfully. We also thank Dr. Jyotika Desai and Dr. Judging the Post. I forgot this. Dr. Pravesh, thank you. And we also express our heartfelt thanks to Mr. Bandari, trustee and management, Jain Hospital, for to render the support for this conference. And the sponsors, we are very much thankful to our sponsors for this conference, workshop by Roche, BioWarriors, LifeCell, MCure, Zuventus, Roves, Mayors, Indoco, and Augmentis Pharma. I'm sure that SMFM conference will continue to get generous support from you in the future also.
We actually traveled quite a bit around the world, and we did it because we had the support of the sponsors, and we got all of them today. And yes, we're really happy about doing that.
Yeah, finally, but not, Mr. Prakash and team for the wonderful AV and technical support. Without any Yes. I'm also thankful to all the EC members of SMFM India who have helped us in organizing this conference successfully. Thanks to all the team members. Thank you.